Let's discuss from here, like part three. So in part three of RGB fitting, we are talking from selection of initial lens. Okay, what are the things that we actually look for the selection of initial lens? Selection of lens diameter based on the corneal diameter, aperture, and lead configuration. We have already talked about it. Yes, total diameter selection depending on three factors. So mainly corneal diameter, definitely. Then other factors are palpebral aperture feature and lead configuration, lead whether it's a lead edges are at appropriate position or not. Then selection of BOZR based on the flattest K. So first we think about flattest K, then after we think about adjusting on that flattest K. So first flattest K is very simple guide for spherical RGB. But then if there is, for example, if there is higher amount of astigmatism, then we will think about correcting that, okay, adjusting that BOZR to be flatter or steeper than the K. So it also depends upon the BOZT, yeah, and a lot of things. Okay, so if more than one power is available, select the lens power closest to the refraction of the person. It's extremely important. If your patient has, for example, -6 diopter refractive error, okay, with some astigmatism, for example, then if you have -3 diopters trial lens and -5 diopter trial lens, you have to go with a -5 diopter trial lens because it's closest to the patient's refractive error. It's always like that. So see, this is the ideal. If you have option to choose anything that is close to that patient's reading, patient's whatever reading, be your patient's radius curvature, patient's for example, patient's SBID, patient's refractive error, that trial lens would be ideal because that trial lens will going to match with the actual lens that you will be prescribing in future. Yes, so trial lens always better, closest to the patient's reading. So empirical fitting, as we are already discussed about our empirical fitting means we definitely measure everything, but we do not do trial fitting. Yes, so sometimes we order the lens and that lens we use as a trial lens, but that's a little bit difficult. Yes. So first we will measure everything like total diameter, back vertex power, and correct back vertex power for the vertex systems, and then we'll do average diameter of the lens. And sometimes if you have computer simulation in your setup, then you can do simulation by putting your corneal topography there, and then you can do simulation. And a lot of corneal topography has that simulation program, which is very helpful program for you. If you have simulation program, yes, simulation program in your corneal topography, or if you have simulation, any type of simulation um, apps or whatever that website you have purchased or your hospital purchased, then it's better you do the simulation because it will give you the closest possible clue. Yeah. So order and use this effectively as a trial lens, but doing trial lens is better than empirical fitting. See, empirical fitting is better in case of soft contact lens because soft contact lens fitting is not that big problem. But in case of corneal lens, especially in case of corneal lens, empirical fitting is like better not to go with. It's better always to do diagnostic fitting. Okay, so what are the basic difference between empirical fitting and diagnostic fitting? Let's discuss about it. So we know the basic empirical fitting is lens is ordered using data. Yes, we will collect the data, for example, K values, refraction topography, SBID, pupil size, and blah blah blah. But then we order directly. We do not do trial lens. So no trial lens is used. We do not trial. But in case of diagnostic, so we select the trial lens on the basis of basically data, yes, and apply it on the eye and assess before ordering. Then we apply on the eye, we put trial lens on the eye, and we assess the trial lens, how's fitting, if fitting is good or not, and then at last we will order. That's the difference, yes. So main idea behind empirical fitting is fit based on the calculation, just calculations. Yes, sometimes if you are lucky enough, then you have simulations. That's better. But diagnostic fitting fit based on real eye observation. That's way better, because we cannot say from the parameters and mathematics how it actually behave on real eye. Yes, so that's why diagnostic fitting is like actually observing real eye observation, how that lens gonna work in real eye situation. Yeah? So advantage of empirical, one of the best advantages is like quick and definitely easy, and good initial vision or less chair time. That's one of the major advantages. So your chair time is less, so no risk of diagnostic lens contamination, and use of topography or lab software effectively, because if you have topography and lab software you use that. These are the advantages, but definitely there is no real eye observation, which is great disadvantage of empirical fitting. At the same time, what are the advantages of diagnostic fitting? It's more accurate fitting, definitely, and fewer order. If, for example, if empirical fitting is not appropriate, then you have to order again. So practitioners have confidence, better patient satisfaction and compliance, definitely, in compare with empirical fitting. So can check centration, movement, and residual astigmatism. These all things can be checked, yes, when you put contact lens to the patient's eye. So disadvantage of empirical fitting, we have already talked about it. Higher chance of refit or reorder. No direct view of lens fit. We cannot view it. At least what we can do is at least see it through the software. Yes. Not ideal. Not at all ideal for irregular contact lens or special design. Not at all. Empirical fitting is not at all ideal. But diagnostic fitting, what are the disadvantages? Definitely more chair time. Yes. Uh, Definitely patient may not get the lens immediately. Obviously it has to order. Patient do not get lens immediately from empirical fitting too, but needs trial lens set. Yes, you need to trial lens set, you need trial lens set, you need to maintain that trial lens set, and you need to maintain the trial lens as uh, good as possible, and possible risk for contamination. Yes, if you are trying to put something in patient's eye, there is always possibility of contamination, like no matter what. So, what are the, why, in which condition empirical fitting is best? Regular corneas, in which you can predict, yes. Routine spherical fit, definitely, and time efficient clinic. So, in that particular case, you can think about this empirical fitting. But diagnostic fitting, it's must in irregular corneas like keratoconus, post-surgical PK's case, yes. Complex lens design, it's always must. So like in difficult case, in literally difficult case for optometrist, it's better that you move with diagnostic fitting. So key point for empirical fitting is like fast, convenient, but less precise, definitely less precise. But diagnostic fitting, slower, hands-on, but more accurate and more confident. You feel more confident as an optometrist practicing optometrist. Let me tell you, you definitely feel confident when you trial the contact lens. So it's really conundrum that you use aesthetics or anesthetics or not. For the very first time, it's better. You can do, but it's not like you can prescribe local anesthetics, or you can suggest patients every time when you are going to put contact RGB contact lenses, put local anesthetics, and you can prescribe it. No, that's absolutely blunder. Yes. So what are the advantages of local anesthetics in case of RGB fitting? Yes, RGB, especially corneal RGB fitting. So one advantage is definitely it will reduce reflex tear and provide patients better initial impression. Yes, but that impression will be false impression, because that's not exactly going to be happen, because every day patient must put his or her contact lens. Yes, so enables quick and more accurate assessment, because uh, lower the adaptation time. If you put anesthetics in your eyes, then definitely it will lower the adaptation time, and you can quickly assess the contact lens speed, but that's not good. So so the topical so the use of topical anesthetics at the fitting and dispensing visit for the first time wearer of rigid lens results in significant fewer drop-offs. Yes, because the most, the very reason of drop-off is the discomfort and the perception that it is very discomforting. Yes, improve initial comfort and give the enhanced perception of adaptation process and greater overall satisfaction after 1 month of the lens wear. So it's definitely controversial. Yes, given by Bennett et al. 1998. But yes, sometimes patient is extremely discomfortable with the RGB lenses. Then you can use one drop at your clinic, at your hospital, but never prescribe, never do that. That's like catastrophe, and it's definitely controversial statement because many of the optometrists do not think that it's necessary to put anesthetics. Many of the optometrists they think that it's better patient sense that feeling. Yes, definitely. So what are the disadvantages? Are toxic to the corneal epithelium and may result in epithelial stain and unrelated lens fitting. It's really, you can read good amount of literature, yes, where patient actually buy anesthetics and use them for like long time. It's not good, not at all good. Yes, so anesthetics are toxic for corneal epithelium, which is not good, and greatly reduce corneal reflex. So any discomfort causes by dirt under the lens or poorly made lens can cause corneal aberration, which will not felt by the patients. So it's like always, yes. So for example, if patient has um, reduced sensation in his cornea by many means, by for example diabetic, yes, and at that particular point these all complications is common. Yes, if he has abrasion then he cannot feel it, and that's big problem because from abrasion it can went to what do you call that, corneal ulcer, even infection, and he can even recognize it. So if corneal sensation is reduced, definitely it will create less discomfort, and patient cannot notice that corneal abrasion, and which may lead to the devastating conditions. Yes. So let's move to assessment of the fit. So white light assessment means basically diameter smaller lens might sit higher or rest on the bottom of the lid and may be less comfortable because of the greater interaction. That's central important concept that everyone must understand. Less comfortable because of greater interaction between upper lid margin and lens edge. This is the reason the interaction between upper lid margin and the lens edge, interaction between upper lid conjunctiva and the lens edge is number one cause for the discomfort. Yes, it's RGP, especially corneal lens are discomfort because of this reason. Yes. Alternatively, lens may irritate the bottom of the lid by dropping between the blinks. If contact lens is not holding by upper lid, it will drop down to the lower lid, and when it's interacting with the lower lid margin, there will definitely be irritation. So, what happens whenever larger the lens? So, interaction with the bottom of the lid as well as the top of the lid interaction with both bottom lids, lens push to lens high riding position, and lens may rest on the bottom of the lid. So whenever bottom of the lid pushes the larger diameter lens, the larger diameter lens can move up, and that we call high riding. Yes. So what we are assessing? We are assessing centration, isn't it? Unless the optical zone maintains the pupil coverage, decentration is acceptable. That's what I am talking about. Centration sometimes doesn't matter because ideal centration is like literally zero. Yes, ideal centration is like extreme rare. But if lens is decentered, but at the same time, just remember this: if lens is decentered, but it cover the pupil, means lens is decentered but coverage is good. We want BOZD, FOZD covers the pupil, yes, to give good vision. So contact lens is decentered, but at the same time, its coverage is good, then it's acceptable. It must be good coverage. It must be move frequently in a same manner. For example, from vertical movement must be smooth. It must be like same whenever blinking. See, this is the center lens. Here is the contact lens. So definitely pupil is not covered. Yes. but this is very centered lens. Okay, so white light assessment means movement. What is the movement? All rigid lens show some movement. Definitely, we want movement. So the task is to assess the, definitely you want to assess extent of movement, but and then you want to assess the speed of movement. Definitely, you want to assess the direction of movement, and this should be observed in a normal primary gaze, not in up gaze or down gaze. Yes. So movement extent. What are the normally post blink movement? We normally think is around 1 to 2 mm. Yes, and it must be smooth. It must be medium to fast, and it must be vertical. So as the lead moves, lens should remain within the limbal area with the superior lens edge ideally positioned under the upper lid. And the lens should return promptly at the same position after each blink, because whenever we blink, upper lid, whenever upper lid goes down on closing eye, and whenever it moves up, then it will definitely take contact lens a little bit up, and then contact lens, after losing that attachment with the upper lid, contact lens slowly moves towards downwards. Yes, and that movement must be like smooth, medium to fast, vertical, and that movement's roughly in measurement 1 to 2 mm. Yes, that is ideal. Yes, extent. So extent of movement, the lens should drop slowly when pushed on the top of the cornea. So that's another important thing. So in case of stiff fit, what happens? Slug is limited post blink movement. Post blink movement is literally like less than 1 mm. Yes, and flat fitting is always there. It's like movement is fast and movement is greater than 2 mm. So direction of movement, a true flat fitting lens moves downward movement in an arcuate direction. So basically, not a smooth vertical movement in flat. It's like arcuate direction. Yes, in case of flat fitting. So smooth movement is like nearly aligned fitting pattern and optimize the comfort and stable vision. Definitely, we want ideal movement is a smooth movement because it's near the alignment of fitting pattern, and definitely it will give comfort and stable vision. So you have to do a lot of practice with contact lens, then you came to know what is smooth means. Yes, and another movement type is apical rotation. When you will see apical rotation, if the lens is fit with the central touch, like central touch means the flat fitting. Yes, central vault means the stiff fitting. Definitely, so rotates about the corneal apex from the superior to the inferior position. So definitely, first it rotates on the corneal apex because it's flat fitting, then it's rotates about the corneal apex from superior to inferior position, and maybe either nasal to temporal position depending upon the how astigmatism is there, and the other part which depend the movement in nasal to temporal. It's like literally like four quadrants of the cornea and their eccentricity. There are a lot of things that matters. Yes. The rocky movement. So what is the rocky movement? As the corneal toricity increases, the lens stability and the movement may becomes more erratic. So that's another point. So basically, whenever corneal toricity increases, basically means cornea more toric, more cylinder, then the movement is more erratic. If the lens is fitting slightly tight to improve the stability, the movement may be limited to a small amount of rocking about the flatter meridian. So that's why about the flatter meridian, lens moves, but in a very small amount. But this kind of movement you can see when you try to fit slightly tighter in definitely astigmatic cornea, and you are fitting spherical contact lens in astigmatic cornea. In that particular case, you will see rocky movement. So white light assessment. So what are the type you will see? So lead attachment. So what is lead assessment? So basically, lens is maintain a high riding position on the cornea between blinks. Basically, upper lid is holding contact lens. With each blink, lens moves through. It is firmly attached to the upper lid. That's why we called it attachment, lead attachment. And when eye is fully opened after each blink, the lens displays very little post-blink movement because lens is attached to the upper lid. That's called lead attachment movement. Two-part movement is like sometimes it's like funny. The lens lead interaction may in some fitting be sufficient to cause the lens to move in two distinct parts. Basically means lens move one part in a different way and another part in a different way. This may apply for smooth and apical rotation type movement. Basically means a smooth movement for particular point and then apical rotation from the particular point. In such a case, lens movement can be noted in a record, for example, smooth in two parts. So because for example if lens contact lens is, for example, this is the cornea and contact lens is moving, for example this is a small contact lens, let's take an example, and whenever it moves this point till this point smoothly, from this point onwards it acts like apical rotation. Yes, because this kind of things happen in toric contact lenses, not toric contact lenses, toric corneas. So this two type of movement is seen in single cornea, and that's called two parts. Yeah. So now it's talking about UV light assessment, which definitely means you put fluorescence, and some books even I could call it dynamic assessment and static assessment. Till now we are talking about dynamic assessment. From now we will talk about static assessment, which assessment with the fluorescent and fluorescent dye. Yes, and UV light basically means a cobalt blue light. So we use 2% of sodium fluorescent and colors the tear, lens field view under the cobalt blue light. After the pattern is observed as the lens move, as the fluorescent drains from behind the lens and each side, thus the dynamic picture and it's not easily represented pictorially. So that's it. So what is fluorescent? If fluorescent is less than 15 micrometer, basically fluorescent is less than 15 micrometer between contact lens and the, what do you call it, cornea, you will not see fluorescent. It's very difficult. And fluorescent greater than 15 micrometer, you will see fluorescent. In this case, can you see at the center fluorescent? No. Here you can see center fluorescent. Yes. So basically means to actually view fluorescent, you have to have fluorescent depth, like literally greater than 15 micrometer. So three primary annular regions on the fluorescent fit should be evaluated systematically, obviously, for basically what you call it, static fitting. So we will observe central fit, peripheral fit, and edge clearance. For any contact lens, that is RGP contact lens, yes, rigid gas permeable, always move from center to periphery. Okay, whenever you move, observe static fitting, whenever you observe fluorescent pattern, always move from center, then mid periphery, then periphery, extreme periphery, then edge. Okay, not from periphery to center. It's very important that you always move from center, mid periphery, and periphery. From center to periphery, it's better. So, to what are the three things you will see in center? It's basically alignment, proper fitting, flat fitting, and stiff fitting. What happens in stiff fitting? Simply central pooling. Yes, that's the fluorescent pattern in mid periphery and periphery, extreme periphery. In alignment pattern, there is no pooling, central light touch, mid periphery light touch, and edge is extremely good. But in case of flat, central touch, see black area, and periphery is like high edge clearance. Yes, and definitely for flat, slight flat, and very flat. Same thing for the stiff fitting. Mid periphery in alignment, it's like perfect, but in stiff fitting, mid periphery like heavy touch, isn't it? And for flat, it's like a little bit touch, but that not that. And just remember one thing: mid periphery is like least distinguished area in contact lens. It's like it's always a dilemma. But yes, in case of stiff fitting, you will see in mid periphery heavy touch. Yes, definitely stiff fit and two stiff fit. See in this picture, what is the difference between stiff fit and two stiff fit? Fluorescent, can you see the color of the fluorescent here? The more greener, yes. And mid periphery, this is dark, it's more darker. Even periphery, the width of that fluorescent, here the width of the fluorescent is even lesser, yes, in compared to from left to right. Yes. Now, finally, the edge fit. Assess the width and the depth of the edge clearance. It's very important. So sometimes depth is difficult, but width is extremely easy. In this picture, we are seeing width, not depth. But in the actual system, you can see depth too. If there is tight fitting, what happens? Narrow edge and inadequate clearance. See, it's it's narrow. Optimum, it's like optimum. For definitely in flat fitting, it's excessive broad area, yes, mid edge fitting. So I think I have to stop here because it's already 26 minutes. I'll definitely talk about from there to end in our next video. So bis dann, tschüss.